My name is Dr. Charles Faiman, the chair of the virtual Grand Rounds sessions on type 2 diabetes. I am a former chairman of the Department of Endocrinology, Diabetes, and Metabolism at the Cleveland Clinic, and currently a consultant in the department. I am pleased to welcome you to this fifth session of the current series on type 2 diabetes, an educational program sponsored by the Cleveland Clinic. As with the prior presentations, we will follow a case-based format. We already have heard about the pandemic of diabetes and obesity in the United States and globally. We also have been provided with management perspectives. Today's session will discuss the management of a typical type 2 patient with a focus on patient adherence. This is a common problem, especially with the polypharmacy currently in vogue to address the various cardiovascular risk factors. The clinician must be aware of the multiple therapeutic options available. Moreover, he or she must also persuade patients to become involved in the decision-making process and to buy into a regimen that they can and will adhere to on a long-term basis. I am pleased, therefore, to welcome our speaker today, Dr. Leann Olansky. Dr. Olansky is currently a staff physician in the Department of Endocrinology, Diabetes, and Metabolism at the Cleveland Clinic. She is a former professor of medicine at the University of Oklahoma. Dr. Olansky is a knowledgeable clinician and a gifted speaker who is asked to speak at numerous local, regional, and national gatherings, particularly regarding management issues in type 2 diabetes patients. Dr. Olansky.
Improving adherence to therapy, a patient-centered approach. I want to start with a case because I think that makes it more meaningful. This is a 62-year-old woman receiving metformin 500 and glyburide 2.5 milligrams BID. Her hemoglobin A1C is 7.5, as it has gradually been trending upward. She admits taking less than the prescribed amount of medication to explain why she refills her 90-day diabetes prescriptions every 4 to 5 months. On further questioning, the patient reports consistency in taking her lisinopril and simvastatin when she takes them before bed. She also states that she's worried that her weight keeps creeping up. Her employer has been encouraging all the employees to improve their lifestyle and offers an exercise program over lunch hour. She tried spending her lunch hour walking but got shaky and had to eat something sweet. One day, she forgot to take her morning medications after fasting for lab test. She discovered that she did not get shaky on that day and did not have to eat something sweet. Since then, she often skips her morning medication and has been able to lose a few pounds, but she admits that her evening blood glucose levels have been a little higher. On physical exam, she has a blood pressure of 140/88, a pulse of 82, a weight of 191 with a height of 5'4". This gives her a BMI of 32.8 kilograms per meter squared, which is in the obesity range. On exam, the obesity is centrally located, but otherwise her exam is unremarkable. The issues to be addressed are the strategies for improving patient adherence. We'll deal with the considerations of cost and access to medication, patient goals, and an introduction of the interdisciplinary team in the treatment plan. The barriers to adherence include cost, side effects, complexity of regimen, and patient fears. And for different patients, different ones of these are going to be predominant. So that's why we really need to understand what it is to this particular patient that causes the problem, and if we address that, we're more likely to get better adherence. Start with a little question, what agent added to metformin is least likely to achieve the hemoglobin A1C targets in this patient? A, continuing glyburide. B, change to pioglitazone. C, change to a DPP-4 inhibitor. D, change to an SGLT-2 inhibitor. E, change to a GLP-1 agonist. F, any of the above could be used. I believe that the answer here is that the glyburide would be the one least likely to achieve her hemoglobin A1 targets. This is the regimen she's been on, and we know that it is failing. And it is failing because of her symptoms of hypoglycemia when she tries to exercise and her weight gain, and that has led to problems with compliance. All of the others are options, and we will deal with those on the next slide. So this represents the algorithm that the American Association of Clinical Endocrinologists have developed to give some guidance to how you might add the next agent in a type 2 patient on metformin who has not reached their goal. So one of the options is a sulfonylurea, as this patient was on. The efficacy is high, at least initially, but there's moderate risk for hypoglycemia. There's an average of 10 pounds of weight gain that patients will experience usually in the first year. The major side effect is hypoglycemia, but this is inexpensive. So for patients in whom cost is the major barrier to adherence, sulfonylureas are a way to get low-cost control of diabetes. One might make the case to change from the glyburide she was on to one of the longer-acting agents such as glimepiride or extended-release glipizide, each of which now are generic and also inexpensive and less likely to have given this patient a problem in the middle of the day when she exercised. Another strategy would be to add a thiazolidinedione. Essentially, because of the restrictions put on rosiglitazone that have now been lifted, pioglitazone is the only drug we have in this category. The efficacy of pioglitazone is high. The risk for hypoglycemia is low if it's not combined with the sulfonylurea or insulin. But the problems include weight gain, a tendency to develop edema, even heart failure in some patients. The cost is no longer really high, but because it's generic, but it hasn't gotten as cheap as a sulfonylurea. But that is an option that the ACE offers you. Another option would be to add a DPP-4 inhibitor. The efficacy is probably a little less than pioglitazone, but the risk for hypoglycemia is equally safe. Here, there's no weight gain. The major side effects are really very rare to have a side effect from a DPP-4 inhibitor, rash probably being the most common. They are expensive because they are not yet generic, and it'll probably be a few years before they are. Another strategy would be to add a GLP-1 receptor agonist. These are very effective, probably equally effective to pioglitazone. The risk for hypoglycemia when used with metformin or used alone is very low. There is some weight loss in most patients, which is an advantage in many of our patients. The major side effect is GI, being nausea and sometimes vomiting. And again, the costs are high because these are newer drugs and not yet available generically. The ACE puts as their next choice insulin, adding a basal insulin, which is also effective but has a high risk for hypoglycemia and is usually associated with weight gain. Hypoglycemia is the main side effect. Insulin is the cost is variable, but it really is not expensive. And remember, you have to do more intensive monitoring of blood glucose if you use insulin because of the risk of hypoglycemia. The same could be said for sulfonylureas, and that has to be factored into the cost of that therapy. Not yet included in the ACE algorithm are the SGLT-2 inhibitors, which work by yet a different mechanism, causing the loss of glucose through the urine. These have efficacy that is similar to the DPP-4 inhibitors. They have a low risk for hypoglycemia. There is some weight loss of about 5 pounds average. The side effects are usually urinary tract, and again, the cost is about the same as those other agents I mentioned. So the algorithm we have for type 2 diabetes, whether it's from the ADA or the ACE or the European Association for the Study of Diabetes, is lifestyle plus metformin at the time of diagnosis as a basis of therapy, and then we add other agents until we achieve a hemoglobin A1C that is less than 7, or the ACE and EASD goal would be 6.5. We know that having a goal of 6.5 will decrease the risk for microvascular complications, and the most recent analysis of the ACCORD data shows we also reduce macrovascular complications, although death was increased in that. So I think we have to address the fact that if we can safely get patients down to 6.5, that there are advantages, but the safely is the important nuance there. Let's deal with each of these separately. So I went through it quickly, but the problems with sulfonylureas are hypoglycemia, and this is especially true if meals are skipped or late, and this makes it very difficult for patients to try to lose weight and control their diabetes with a sulfonylurea. The risk is also increased with exercise, which is another problem in those patients trying to lose weight. Renal insufficiency also increases the risk for hypoglycemia. So weight gain is an issue, and lack of durability. In the ADOPT trial, when patients with type 2 diabetes were started on initial therapy, patients had their first very nice response to glyburide, but within the first year there were patients who were failing this therapy and had to have another kind of therapy added. So durability is a concern, and so that affects our long-term plans in the use of this drug. Some of the alternatives we could use in place of a sulfonylurea if we wanted to have an insulin secretagogue would be nitaglinide, repaglinide, or incretin-based secretagogues. Nitaglinide and repaglinide are both short-acting secretagogues that are taken just before the meal and therefore are somewhat safer. This patient could skip taking that if she was going to walk at lunch and probably would not go low in combination with her metformin. Another strategy would be to use an incretin-based secretagogue. Incretins are endogenous secretagogues that are secreted by the gut in response to food in the lumen of the gut. They are, if you'd like, intelligent secretagogues because they will stimulate the production of more insulin from the beta cells, but only in a glucose-dependent fashion. Once the glucose gets to normal, these agents stop increasing the release of insulin, and therefore they are intrinsically very safe. What is the limiting factor in incretin therapy? And that is that these drugs are short-acting. Advantages is that the insulin production is glucose-dependent. That means there's no hypoglycemia if not combined with insulin or sulfonylurea agents. There is suppression of glucagon, which is contributing to inappropriate production of glucose from the liver and adds to the overall requirement for insulin, and these drugs are weight neutral. The DPP-4 inhibitors work by leveraging the endogenous incretins, GLP-1 and GIP, that are produced in response to food, and by inhibiting their breakdown, increase the length of time that these are elevated. So we see more of an effect as far as stimulating insulin, and when it comes to increases in GLP-1, reductions in glucagon, which have a synergistic effect in lowering blood glucose. So they are extremely safe because all of the insulin stimulation and the glucagon suppression are glucose dependent. And once the glucose levels get down to normal, you no longer have an effect on either beta or alpha cell secretion. The DPP-4 inhibitors, there are 4 that are available in the United States. This includes sitagliptin, saxagliptin, linagliptin, and allagliptin. Another agent, vildagliptin, is available worldwide. There are no generics yet, so the agents are relatively expensive. The advantages of the GLP-1 agonist are that they are a little more effective at glucose lowering than DPP-4 inhibitors. There is associated weight loss, usually an average of 5%, that is maintained over at least several years. There tends to be an improvement in blood pressure and in lipids. This makes it easier for us to hit our other targets that we have for our patients. Well, what are the issues with GLP-1 agonists that might be a deterrent to a patient using them? Well, they're all injectable, and I think for the long term, that is the expectation. They'll all be injectable. For some patients, having to give an injection is a major barrier. So that is going to be a reason for some patients to not consider this. They can cause nausea and vomiting, especially if there's underlying gastroparesis. The longer-acting agents seem to have less nausea and less vomiting than the early short-acting agent. There are no generics, so that's relatively expensive, but covered by most insurance plans. As far as the GLP-1 agonists go, there are 4 approved now. Liraglutide, which is a daily injection. Exenditide exists in the original BID form that had to be given twice a day, usually before breakfast and before dinner, but had to be the dinner had to be eaten within an hour. But the matrix form of this that has allowed a weekly injection has really made this a much more easily used drug. That originally had to be mixed with component parts in a powder with a diluent and drawn up in a syringe and then a needle put on. But in the last few months, it has come out in a pen where mixing is still required, but all of the components are in the pen, and there's nothing that has to be done except twisting, mixing, and the attachment of the needle, which makes this a little bit easier to use. You patients have to get this together and inject it in about 5 minutes, or it starts to set up, and it's possible to waste a dose if it's not handled correctly. Albaglutide is also a weekly injection. It uses a different strategy for its long half-life. It also comes in a pen with a diluent and a powder that has to be mixed. This has a much more tolerant time frame. You have to wait at least 15 minutes before you give the low dose, or 30 minutes before you give the higher dose of mixing, and you can wait as long as 8 hours. So patients need to get it mixed, and then they let it sit for 15 minutes or 30 minutes, depending on the dose, and can leave it up to 8 hours. again, this may be a deterrent to some patients that just don't want to have anything that is at all complicated. And the most recently approved delaglutide is a weekly injection. It uses yet a different strategy. It's already in solution, comes in a pen. Patients just have to twist it to activate it. The needle is not visible. They put it up against their skin and push the button, and it triggers the time that tells them when they can pull the needle out. And so for patients who really want minimal kinds of interaction, liraglutide and delaglutide are easier than the others, but I think these are all very reasonable options for the average patient. Thiazolidinediones, again, they've been around for 20 years. There's no risk of hypoglycemia. Pioglitazone is now generic, so it should be less expensive, although patients tell me it's still not really cheap. Pioglitazone has benefits on lipids, it lowers blood pressure, and it has an overall very clean safety profile. But what is the baggage that goes with TZDs? They can cause edema. They can even cause heart failure from fluid retention in susceptible patients. There's usually weight gain. There was an increase in fractures, so the concern for osteoporosis. There was also a concern about bladder cancer, but that's recently been disproven when the studies of long-term usage were examined. Patients followed out 10 years. There seems to be no risk from TZDs in bladder cancer. The SGLT-2 inhibitors may be agents you're less familiar with. These are also orally active agents. They have a mild weight loss, usually of about 5 pounds. They also have a mild blood pressure lowering effect. So again, if your patient needs a little bit more to get their blood pressure down, this might be a good way to go. It works by increasing the loss of glucose in the urine by inhibiting the reabsorption of glucose in the renal tubules. There are 3 agents available in the U.S., Canagliflozin, Dapagliflozin, or Empagliflozin. So if the drug ends in gliflozin, you can be pretty sure you're dealing with an SGLT-2 inhibitor. All of these drugs come in 2 doses, and their effects are comparable if you use corresponding doses. The SGLT-2 inhibitors, they're new, no generics, so relatively expensive in the same order of the other agents we talked about. There is an increased risk for urinary tract infections and genital infections, particularly in women. This is primarily a problem in women that have had the problem before, so those that have a tendency to have UTIs and candida vaginitis probably are not the best candidates for this. Also not a great choice if the patients have a problem of incontinence or in men that have BPH. And because of the way it works, it's not going to be effective, and it's not FDA approved if you have severe renal compromise. In fact, as the GFR decreases, they become less and less effective. They also have no risk for hypoglycemia if not used with insulin or with an insulin secretagogue. So again, safe in that way. So the patient needs to be involved for us to choose for this particular patient what is the best. We want to address her perspective. What are her goals? How can her goals be incorporated into your goals? So what choice of medications are going to make it most likely that she will adhere to the program and follow through. So we want to get her involved in the choice of the next step after metformin, so I think we need to give her the particulars on each of these agents. The advantage to this is we have patient buy-in. So that takes away her concerns that have been a barrier to adherence. And it emphasizes, I think, to her what an important part of the team she is. Nothing happens if she's not on board. So let's get back to the case. She has good insurance that will cover generics at Tier 1 and brand name agents used as the FDA has approved them at Tier 2. We can increase her metformin to 1,000 BID if she's not having significant gastrointestinal symptoms, and that should be done, and discontinue the sulfonylurea. Despite the need for injection and the possible nausea, the patient wants to try a GLP-1 mimetic because she's really interested in losing some weight. That's her greatest concern. She would expect to lose about 5% and maintain that over the next several years. Also, her blood pressure and lipids will probably be easier to maintain those within the targets that we have for her. If she doesn't tolerate the GLP-1 agent, probably her backup choice would be a DPP-4 inhibitor, because this is not going to interfere with her exercise efforts, and that may lead to some weight loss as well. The interdisciplinary team can help the patient with dietary modifications that make it easier to lose weight. It helps her with other lifestyle changes and hopefully adds to her understanding, which also helps with adherence. A diabetes educator can teach the patient how to use the pen device for administration. Like I tried to indicate, the simplicity varies with the various agents, and the educator might be helpful in pointing out which patients need to be steered away from the more complicated ones. If a diabetes educator is not available, pharmaceutical companies have support systems that can help the patient get started. A follow-up call from the educator or from your office staff can ensure that the patient follows through and to identify any problems they're having. This also will improve adherence. And I would ask the patient to return to your office in 2 to 4 weeks for a weigh-in. Usually they've lost a couple of pounds if they've been on a GLP-1 agonist, or they're seeing better blood sugars. And we want to make sure that the choice that was made initially was a viable one, and that if not, we'll go to something else so that we can maintain good hemoglobin A1C as well as blood pressure and cholesterol goals. So the patient-centered approach addresses cost, side effects, complexity of the regime, and the patient's concerned. And the prioritization of these various things is going to be very patient-specific. For her, she was worried about weight, and she wanted to be able to exercise. For some patients, cost is primary. So we need to know where the patient's coming from, and therefore we can address that. That really increases the chance of patient adherence. Individualization is key. Patient buy-in improves adherence. This allows the patient to realize that she is an important member of the healthcare team. And I think we're left with the lesson that despite the added expense of the newer agents that are weight neutral or can cause weight loss and help maintain blood pressure and lipids within target range, that these probably help balance off the added expense of the newer agents. Again, that is a patient-dependent issue. Thank you very much.
Thank you so much, Dr. Olansky, for that insightful look into therapeutic options, target goals, and helpful tips to improve patient adherence. Numerous studies have shown that a major stumbling block in managing chronic disease is long-term patient adherence. The number of agents used, complexity of the drug regimen, side effects, and cost are major factors in the equation. As underscored by Dr. Olansky, patient buy-in is of critical importance. Frequent follow-up, especially early on, helps to promote adherence and to deal with such issues as efficacy, tolerability, and cost. Over the long haul, as newer agents become available, a rediscussion can be helpful. From a multiple drug viewpoint, it has been shown that combined agents appear to promote adherence. Accordingly, attention should be made to combining effective and tolerable agents when such combinations exist. Combinations usually have a cost advantage as well. Some clinicians argue that combined agents can be initiated at the get-go, a concept that I am reluctant to recommend since a side effect may preclude the future use of both agents in the combination. Side effects will clearly play a role in optimizing drug choices. For example, weight gain and hypoglycemia with sulfonylurea use in today's patient demanded a change in the regimen. In others, GI intolerability, for example with metformin or a GLP-1 mimetic, will dictate the use of alternative agents. Cost is becoming a more and more important factor in patient adherence. The complex and confusing arrangements of formulary coverage, deductibles, and donut holes in insurance coverage all contribute negatively to patient adherence. It is clear that the busy clinician cannot be expected to memorize all patients' formularies or know when donut holes are being reached. However, cost as a potential burden and stumbling block regarding patient adherence must be acknowledged. It should also be recognized that a number of pharmaceutical companies have provided a safety net whereby truly indigent patients can receive appropriate drug coverage. As emphasized by Dr. Olansky, a multidisciplinary approach can support adherence success, resulting in more effective management of diabetes care. Patient education and buy-in are the critical elements of the multidisciplinary team's focus. An often neglected component of the team is the pharmacist, whose interventions can positively influence both health outcomes and patient satisfaction. In closing, on behalf of myself, Dr. Olansky, and the Cleveland Clinic, I wish to thank you for attending this 5th session in our current series of virtual grand rounds on diabetes.